This is the Situation Room, the only way to start your day.
The point when they are sick. So ukifika pale hospitali ndio sasa unataka matibabu, then unajikuta uja-register, hapo ndio unataka kwanza kuregister na uanze kulipa. Unlike how it was working with NHIF. I don't know whether that is also another issue that now is on these, a problem that is now coming from this other end. And the gentleman with the microphone at the back, you can stand and then say your name, what you do, and your comments.
My name's Joseph Macharia, community member and youth leader at Kariobangi North. And I'm also a member of Kariobangi Social Justice Center and Mama Zetu CBO, and also a CHP community health promoter. Mm-hmm. So I would like to state part of the Constitution, Article 43, Part 1 of the Constitution states that every person has the right to the highest attainable standard of health, which includes the right to health care services and reproductive health. But from my angle of understanding and view of SHA, it was a good project and idea. I think it was borrowed from the western side of the world, but it has faced a lot of glitches and hitches here and there because we didn't build the right infrastructure at the inception stage. So that's why we are seeing issues of like currently we are still facing issues of inadequate medical supplies at the healthcare facilities. We still don't have we are still having inadequate number of medical personnel at the health facilities. And that's why we are also having issues of interns striking, the nuns on the strike, because SHA is not yet self-sustaining. So as much as it is being inasifiwa sana na wanasiasa, bado iko na changamoto sana mingi hapa kwa ground. Na ndiyo maana there is a lot of mistrust about SHA because there was no enough public awareness and understanding about SHA. So I think we still have a long way to go. And just like Daktari has said, if SHA doesn't maybe clear the debts that are being owed to the other the public and private facilities, in the next maybe few months we'll be having a crisis. And it's a high time that the government takes charge of the situation, and so that tuweze kufanya kazi safi kwa wananchi pale kwa ground like CHPs, sababu tukienda pale kwa households, people still think that SHA is like NHIF, ile ambayo ulikuwa tunachukua NHIF unaregister kama ni bibi ama mzee, pale ndani yake tunaweka bibi na watoto wanakava wote hivyo. Lakini sasa SHA ni different, sababu as long as you are 18 years old, you are an individual on your own na unafaa kuwa covered on your own self. So tunapata inakuwa na hizo changamoto, sababu ndio umeregister, but if kama wewe ni CHP na hujui kujaza zile premium test questions, utajipata kwa shida, sababu utajazia client and then pale premiums zikikuja pale chini, the monthly premiums, unapata the amount is too high. Like mimi nilijijazia yangu and monthly yangu ikakuja ikaingia 1200. So if you multiply 1200 times 12 months, that is 14,400. And if you look at my incomes and revenues, they don't even total to that in like in a month.
Collectively.
Yeah, collectively. So unapata mimi kulipa ile 1200 for in a month, naona kidogo ni challenge. because kwa akili yangu mimi nilikuwa najua pengine ni ile ya 300 ingekuja kidogo haingeniumiza. So naona kuna changamoto mingi na we still have a long way to go.
A long way to go.
Thank you.
And what about you, sir?
Hello, my name is Stephen Odongo. I work at the grassroots level of Kariobangi North with the young mothers, matters maternal and newborn health. And the experiences of SHA out there are different. Many people are still stuck in between the old NHIF and the SHA. And they are wondering what next. We are told to register, but there is no clear explanation of what happened to our contributions on NHIF. And now the problem is there is no clear information. The politicians are just politicizing the matter. And currently, I'm working, for example, with a cancer patient who is required to pay an upfront of up to 1 year in premiums to SHA before she starts the chemo processes.
Okay.
And now she has to stay at home to raise that money. A person who cannot even afford that common bread. So the cancer is eating into the body because it's waiting to pay for 1 year treatment. So it's a challenge.
So I'm sorry,
Recently,
Odongo, 1 year treatment or 1 year of premiums?
1 year of premiums.
Okay.
Yes. And for that is difficult for people without income. Recently, doctors have been on strike, and many people ran to private hospitals to get assistance for those who are delivering. They go there and they are told that, if you are going to deliver through a CS, without SHA, you will pay up to 60,000 cash. And with SHA, you will pay a little bit lower. So they are like, I cannot even raise that 1 year payment. Where am I going to get 60,000 cash? So it is a problem that is facing the people at the grassroots level.
Let's stay there a little bit more, Odongo. Can we kidogo too? So this is a woman who is not going to get pregnant. Si ati anafikiria atapata mimba mbeleni. Saa hii akona mimba, right?
Yeah.
Anafaa kuenda kujifungua. Si ndio?
Yeah.
And she's told ukileta cash ni 60,000.
60,000.
Na ulikuwa umeshasema kupata chakula on a daily basis is already an issue.
It's an issue,
right?
Yes.
And we are now saying kujifungua utalipa 60,000 kama unaleta cash.
Yes.
It's a little bit less with SHA. But SHA haujalipa hiyo 12,000 for the year.
Yes.
So the question is, wamama wanaenda kujifungua wapi?
Now that is where the problem is. Yeah. Because that already adds to the existing problems for most health centers down there, where even when you have paid that premium, the beds are not enough. Some health facilities do not even have medicine. They have to write for you to get it out there. Yeah. So it is a problem, and I think we need to have a serious conversation about the whole SHA stuff. And that the politicians, the leaders need to come out and to start telling people the truth that we need to build trust with SHA, because this is public money. If they messed up the old NHIF, then this new model, it's a good idea, but can we have a clear conversation with everybody so that they can understand what they are dealing with and they can benefit? Because few people maybe they are benefiting from it, but many are still questioning what is it. Yeah.
Maybe we can hear from this gentleman who
gentleman
hasn't
in front.
spoken, and then we can go to Daktari.
Good morning.
Morning.
My name is Simon. I'm a community gatekeeper at Mukuru, and also I'm the chairman of Embaka South Community Health Promoters Association. That's Association of CHPs, and also working as a coordinator in the climate works in Mukuru Kwanjenga. So for now, on the issues of SHA, that is working, not working, to me is like you are not seeing trees and the forest at the same time. Because current people are jobless, some are so vulnerable, such that to afford medical services through SHA, they can't. And one of the president was saying that the vulnerables would be allowed to be treated free. Yet, there's no criteria, there's no mechanism put in place to identify the beneficiaries. So that meaning all clients who are sick at the households, they are yet to get to hospital because they can't afford. Simply because when you get into any hospital, you ask a public hospital, you ask for SHA. That's the first time. And if you are not registered, then duly you have to get registered, and you have to pay for the treatment. So you just get away. They are getting to the chemist around.
What? Okay. Sorry. People are coming to hospital with issues, with
Yes.
medical problems.
The vulnerables.
Tell me some of the issues. Ugonjwa gani wanakujanga hospitali nayo?
So kuna watu wanapitia magonjwa kama NCDs.
Kama nini?
Kuna
high blood pressure,
wenye wa blood pressure, diabetes. That's also cancer.
Cancer.
Tuweke zote hapa.
Sasa ukikuja ukienda hospitali na wanakuambia uwezi pata usaidizi juu haujalipa
SHA,
unaenda kwa chemist,
you just unaishia tu kutoka tu kurudi kwa nyumba.
Kufanya nini?
Na hauna njia utatibiwa. Hauna njia. Unless you get a cash, unaenda public hospital or private hospitals. You get a cash.
Unasema watu wanarudi nyumbani juu hawajapata usaidizi, wanarudi na ugonjwa, wanarudi kwa nyumba.
Yes.
I want to talk to Catherine just a little bit. You had tried to talk to us before we had a bit of a sound issue. Ndio shida pia wewe unaona, ulisema unafanya kazi huko Mkuru?
Yes.
Okay, tell us please.
Mimi naona pale unaenda unaregister. Watu wengi wameregister. Yes. Lakini kulipa wanjalipa. Kuregister si free. Mtu anaenda register. Akimaliza kuregister anakaa tu. Siku ya kwenda hospitali ndio anaenda anaambiwa pale mpaka ulipe 1 year. Ndio access services. As for me, nilikuwa na client nikalipa 1 year 6,000, alikuwa amelipishwa 500, nikalipa 6,000, alikuwa anaenda delivery. After 3 days kama amejifungua mtoto akawa discharge, then akawa mgonjwa, ikawa niende higher hospital. Vile nilienda ilibidi sasa for the first time nimelipa SHA 6,000. Sasa ni kwa outpatient, nitoe pesa kwa mfuko. Nikienda pande hii unalipa, ukienda pande hii 3,000, ukienda pande hii 2,200, 300. At the end of the day akawa admitted. Though alikuja kutolewa yes na SHA, lakini umelipa SHA ikusaidie, na tena unaingia kwa mfuko unatoa cash. So hiyo kitu ikawa imenichanganya sana.
Kuna kitu umesema, kuna that example ya mtu ameregister lakini watu hawalipi. So watu wana register juu ni bure, hawalipi juu hawajui wanafaa kulipa, ama ni ile unajua unafaa kulipa lakini kwa sababu uko mgonjwa hakuna haja ya kulipa, lakini wacha ni register. Lakini ile siku uko mgonjwa ndio sana unakimbia hospitali, then unaambiwa kwa system records zinaonyesha umeregister lakini hujalipa, sasa lipa
Premium. Unapata nimeambiwa pale nilipe 8, kama mimi nimeambiwa nipe 650. sina hiyo 650. So wakati mwingine unaona ni challenge kulipa. Sasa wanakosa kulipa kwa sababu ya pesa. Hawana hiyo pesa. Mtu amepewa pesa yenye hawezi lipa, hawezi pata. So anaona kuliko niendelee na kung'ang'ana na hii pesa, na mimi maybe ni naumwa na kichwa. Naona niende pale chemist ninunue Panadol. Though sijapimwa lakini ninunue Panadol. Nimeze.
Na utakaa tu mpaka
sasa si hapo sasa. Hiyo ndio shida tuko nayo.
You know, it's interesting. I went to a chemist. I've just remembered this. I mean, this flu cold that is doing rounds.
yeah.
So I went to this chemist, and there was a queue. And I stood there waiting. I knew what I wanted to buy, but there was a queue. And what I observed is people are now resorting to use the people behind the counter to consult.
Yeah.
So you're going and explaining, because the assumption is this person who's giving you the medicine ni daktari. So namwambia nasikia naumwa na kichwa, kifua unasikia, nasikia, na hii nasikia, because you're not paying for that, it's free. Then they would recommend medicine. The challenge now with that is it's so easy to take medicine from somebody who's not really qualified to diagnose, because there's no testing at that chemist. And my question to Daktari, listening to this conversation, it almost, because I'm hearing two things. I'm hearing, one, there is the issue of, looking at the general conversation, SHA and access. There's inadequate medical personnel. Somebody raised it, that you go to a hospital, the doctors are not enough. Then there's the issue of lack of medicine. Even if you access, still not enough. So which brings me to the beds are not enough, which now brings us to this question. Giving universal health care and access, was SHA then fixing an access problem but not care? Because it almost seems like, fine, if you've paid the premiums and then you can access, there is another challenge. Either there are not enough doctors and nurses, there's not enough medication, or there's no equipment, you want to go for dialysis, there is nothing you can do, but you still have access. Is SHA fixing an access problem only?
So, first of all, you know, the last 20 minutes, I have just been listening to the panel, and we have a very good panel. This is very intense, even for me to hear, despite being on the provider side. The experiences of Kenyans, vile mmesema kwa ground, you know. And before I even, okay, let me just answer your question straight. So SHA was not fixing an access problem. If you look at, SHA was fixing a funding problem. So the drafters of SHA, the idea they had in mind is that we need a lot more money to cover many more Kenyans. That NHIF wasn't covering enough Kenyans. Because the total number of, at peak, if you contributors plus dependents under NHIF was 15 million. 15 million, that's the best we did. We have a country which is 55 million going 60. So their argument was, you are only covering a quarter of the population, that is too few people, and therefore a lot of people are incurring, you know the sound bites. Harambes will be over, you know, all those things. So the first problem they tried to fix was a healthcare financing funding problem. And to that extent, they had some good ideas. Let me give you what the good ideas. Primary healthcare fund, independent, funded by Parliament. Fantastic idea. Emergency chronic and critical illness fund, which was to align our financing with the constitution, that no Kenyan will be denied healthcare because of an emergency. So they set up the Emergency Chronic and Critical Illness Fund, again funded by Parliament. And then we have the elephant in the room called the SHIF Fund, which is what we are all discussing, the contribution. Now, if you realize, during the first budget, the financing to primary healthcare and emergency was very low. And people made a lot of noise about that financing. In this current budget, they increased it to 13 billion for primary healthcare and 10 billion for emergency chronic and critical illness fund. The 13 billion for primary healthcare is being dispersed. Some counties are getting, some counties have problems. About, some 8 or 10 counties have problems. Other counties are getting. The emergency chronic and critical illness fund, unfortunately, has not been activated. Even if you look at the data of claims coming in for ECCIF, it's for the 10 billion, the last one, a few months, they have only generated claims worth about 500 million. Very little, very small amount of claims. So that fund is not active. And if you ask them today whether they know if I am in an emergency, I can go to Aga Khan, most people don't know. People know that they can go to Nairobi Hospital.
Can you go in an
go
emergency?
to Mata? Yeah. According to the law, if today you have you get run by hit by a motorbike in Parklands, if you are Ruko Parklands, you are walking and you are hit by a boda accidentally, the law says you can be rushed to the nearest hospital, which will be Aga Khan Hospital, whichever,
and they must treat you.
And if you are SHA registered, even if the bill within the first 24 hours is 500,000, SHA should pay. But
how many people know this?
How many people know this? People don't know this. They don't know. If you have an accident somewhere on Agings Kodek and the nearest hospital is Nairobi Hospital, the law says for the first 24 hours, whatever bill they incur, even if it's 1 million, SHA will pay.
Will pay.
Now, how many
that?
Kenyans know that?
Nobody knows
I am
that?
sure. Even in the communities where you are, you see accidents every day. Mtu amegongwa. And when they are taken to the hospital, they ask for money up front. But the thing is, the Emergency Chronic and Critical Illness Fund is funded, but it's not activated for two reasons. I don't know why they are not educating people about this, to tell them this benefit is there. And number two, for us as providers, within our SHA portal, we need to have activation of the module, so that when a patient comes in as an emergency, I know, okay, Erastus is here, he's been run by a vehicle, I will click here, I will submit a claim. That is not there. So the healthcare financing was the main issue. But I would say this, where is the rain beating us on the public side?
Yes.
Education, obviously, you can hear people don't know. And by the way, this government has been taken to court numerous times because of the issue of public participation. Numerous times. In fact, these SHA laws almost fell because of lack of public participation. They have not done effective public participation. The public participation they have been doing is for checking a box. They just want to show watu walikutana mahali, wakaongea, wakatick box. But they have not really invested in telling the Kenyan people, because, and I think it's largely is because of politics. Because if when you take this thing to the ground and you tell people the reality that your premiums will go up, the politicians are afraid that it will make them unpopular. So they gloss over it. The other thing is, let me just, on that healthcare financing issue, somebody mentioned it here. If you are over 18, you are now a household. Isn't it? If you are over 18, you are considered a household unless you show that you are in school or something. But generally, you are a household. So I want you to imagine families where you have mzee and mama and 3 children who are all over 18. Because, we have employment crisis in this country. A lot of kids are staying home well past 18 into 20s, even 30s now. Yes. Because, there's no work out here for them to go do. So they stay in the same house. Now, that house with 4 people, everybody there is an adult, has an ID. Do you know everybody there is a contributor in that same house? And yet maybe the person who has income in that house is one person. Only one person. Now, these are the problems, this is a major problem. We proposed to them. We proposed to them that instead of having everybody in the house being a contributor, because they will not, that burden is impossible. Okay? Why don't you have like a family package? You say, this house, nyumba iko na watu 4, let us give them a flat rate. Wakilipa hiyo, the whole house is covered. These are basic things that they haven't done. The other basic thing is like with the Lipa SHA Pole Pole. Let Lipa SHA Pole Pole actually be Lipa SHA Pole Pole. It should be micro premiums. Allow people to pay daily, weekly, monthly, kulingana na uwezo ya mtu.
That's an interesting, Dr. Leshenga. So I just want to hear, would it make sense, for example, Saeed, because we have people, and this is the scary thing for me, because when we look at other matters of health, I'm trying to imagine, if we just look at maternal care, there's Odongo works with maternal care, for example. A woman is pregnant to give birth. And she can't do that if she's not paid, obviously. And she doesn't have the cash, even if it was 20,000 shillings, which is a third of what it would cost at the hospital. Even if it was 20,000 bob, she doesn't have that money to pay. We already know, for example, that with maternal death, that postpartum hemorrhage is one of the highest causes of maternal death. We know cervical cancer is the number 2 killer for cancers in Kenya. The number 1 is breast cancer. These are non-communicable diseases that people cannot go and get treatment for in hospital. We can't even do prevention, which according to the Ministry of Health, we are going from curative to preventative care. Scanning cannot happen. So many things cannot happen at the same time. But a mother who is about to give birth, just as an example, and doesn't have the care, I'm still asking the question, where does she go? What does she do? Do we have more women giving birth at home? Do we have more women giving birth where she is and there's somebody who's going to rally around to help her? Because what are we talking about here? And that last question that you asked, do people, even if you were to pay a little, what would make sense? You know? Because these are the issues.
Maybe I can take the question of what would make sense. And we have proposed this. In this country right now, we think that a fair premium on average should be somewhere between 600 and 900 and no more. Should not go there. So that would be like the most effective premium. But we need to break it down to something like 20 bob a day, 150 a week, 300 a month, whatever. We need to break it down to manageable levels so that wananchi can actually afford it. There are so many good ideas. For instance, why haven't we used chamas as aggregators for helping the community to pay? And you know, chamas can do this very well. We have a lot of chamas out here. If you go to any particular ward, I don't know how many chamas you can find. You can find hundreds of chamas. But we can incentivize chamas to be collectors for us and give them a small token, 0.1, 0.5%. If your households are contributing under the chama, we give them some check, a bonus over the... Do you know what we are doing with these empowerment rallies that politicians are doing? You know, you gather women groups and you give them, and people end up with 64 bobs, 100 bob. What if we converted those empowerments into SHA drives, you know, so that, for instance, if a chama is very effective in getting people to contribute this small amount of money, they get their 50K check. Okay. Why not?
Does it make sense? I mean, it's the lady in the purple. Sorry, just remind me your name, because you talked about working in the grassroots. We know these chamas. We know women. Catherine, both Catherines can tell us. And also we know that it happens, for example, that you are in a chama whereby you're putting 50 bob on every Tuesday, you're putting 50 on Friday, you're putting 20 on Tuesday. So maybe in a week here, ukisema, you can get 300 bob in the different chamas, and then on what day you collect. It happens, doesn't it? So would it make sense if for even this SHA, because it's a problem, people are sick, right? Would it make sense if they say, put a little bit of money, if 20 bob a day, because you can gather it, 20 bob a day, let it go towards SHA. If that came up, would it make sense?
I absolutely agree. It will make sense in that perspective. But there's a survey that we conducted where we asked women, what do they want for their health? And surprisingly, one of the key things that they say they want is money. So it comes down to money. But where do we get this money? This woman can't afford the 6,000 per year that she's been requested for. But with the 10 shillings, 20 shillings each day, she's able to contribute that money towards the M-Pesa. If you can have the M-Pesa, what the doctor was saying, let's have the Lipa Pole Pole for the SHA. So we... And the question around even maternal health, because we also work within maternal health, where right now we are seeing a rise in women now giving birth through the traditional birth attendants. At least during the Linda Mama, those cases were coming down. But right now we are seeing a rise, and also we are seeing also a rise in maternal health, in newborn health. And today, even the WHO is now... The key things that they are focusing on is bringing down the maternal deaths and neonatal deaths. But if we cannot fix the financing issue, then I don't see ourselves fixing the maternal health crisis that is happening, fixing the neonatal death crisis that's happening at the community levels. And we have CHPs here, and they will tell you, right now women are afraid to go to the hospital to seek the skilled birth attendants because they know they'll get charged. Within Linda Mama, you'll go in, and come out and your services are free. But right now you have to consider now, I have to have cotton wool. For example, we provided even some cotton wool to within the communities, because you're asked, you cannot go to this hospital without cotton wool, and cotton wool is one of the essentials that you need when giving birth. So if this woman does not have that cotton wool, what will she do?
Wait, just hang on there. This is very heavy. I'm sorry. I mean, it's your reality on the ground. On this other side, these are horrendous stories we're hearing. So you're saying this mother has to look for cotton wool. Is this communication from hospital that, look, ukikuja kuja kama umejipanga, or how is it happening?
It's communication from the hospital. You come with the maternity pads or the cotton wool that you need. So even when we're doing activations around, or we are teaching mothers about maybe how to take care of their pregnancy at community level and giving them basic information, they tell us now, you've given us the information, but when I go to the hospital to give birth, I need that cotton wool. I need that to provide that cotton wool. I need that maternity pad, and I don't have the money for it. So they're asking us if you can provide for us, so that when the time comes for me to give birth, I'll go with these things. And maybe the CHPs can confirm this because we have them here. And we have done this in the community, Kariobangi community. Also, we did it like 2 weeks ago, where we provided women with cotton wool and maternity pads. This is the reality on the ground, and maybe they can confirm this for us, so that we...
Well, I mean, Odongo is sitting next to you. He works with maternal, and also Catherine is there as well. So maybe we can hear from both of you as well.
Yes, that is very true. When it comes to expectant women, they need these essentials to use during delivery. Now, apart from the contribution they need to pay in the hospital, they need to have these things with them. And that is also trickles down to the finances they need to have with them. So about the chamas, it's a perfect, brilliant idea, but it may not always be the case, because most people live from hand to mouth. Even the little they get to feed the family, they need to maybe spare and keep for this. Pregnancy is about 9 months. Sometimes you live with a person who is not well off. They don't have income, and therefore you are basically yourself. So you need to have these things ready by the time you are delivering. So it is difficult. And basically I've heard also recently that many children have been detained in hospitals because of the huge bills. So if the delivery comes, you have to go and deliver whether you don't have any money with you or not. So once you have delivered, you see, they will keep you there until somebody comes along and maybe settles your bill. So it is still a problem for many women.
Yes, ma'am.
Asante. Kuhusu, nitaongea juu ya vile daktari amesema vyama. Hakika hata tukifanya vyama ni vizuri, but we shall not cover the whole community. Juu kuna wale watu wa chini kabisa. Kama sisi community health promoters, tuna end up by, wewe unakula kwako, maybe umestruggle, umepata yako, umekula. And your household neighbor to you, akona watoto, na hata hawezi raise 20 bob.
20 shillings?
Yes. Kuna watu vulnerable, totally vulnerable. Mtu kama huyo tiari atabaki nje, hataweza hiyo chama. Wale tu tutaweza ile chama, huenda ni wale watu wako well off kidogo, wale ambao tunaona hata 6,000 per year, it's a lot. Sasa hiyo hatuta cover the whole community. Juu kuna watu wale hawana kabisa. Kabisa ukiona, unaona hana, mpaka anaenda kutafuta huko chakula nyimetupwa huko anakula. Mtu kama huyo hata 20 bob hawezi.
Na watoto?
Pia analeta tu hiyo, kama amepata. Kama ametoka, watoto pia wametoka, wameenda. Unaona sasa situation kama hiyo ni ngumu. Nikikuja kwa mama wajawazito, ni ukweli. Hakuna hizo pads, hakuna hizo cotton wool. Wewe CHP mwenye uko na household yako, unapeleka mama pale. Hapo nyuma vile kumekuanga hata na hiyo linda mama, utagaramia. Utajua vile huyo mama atatoka kwa nyumba hata kama ni saa ngapi, kwanza security wise. Umpeleke hospitali, ujue vile atajifungua, hautamwacha huko na mdambu. Mpaka ujue vile atatoka arudi kwa nyumba, hata kama akona watu wake utasaidia. Sasa ikifika hapo kwa cotton wool na nini, kama hana, you will provide kama health promoter.
You will provide from where?
Wewe sasa wewe utajua juu hii ni kazi yako. Tumekubali kufanya kazi ya community. Kitambo tulikuwa tunaitwa volunteers. But sasa ndio community health promoter juu ya stipend kado. Hiyo 3500 hata mimi mwenyewe siwezi jilipia hiyo SHA. Nifanye yale yanatakikana na ni obvious 100 households 3/4 maybe hawajiwezi vile tu mtu anaweza kujisustain. Alafu kitu kingine, daktari
unapatiwa 3500 per month.
Yes, stipend.
Ndio stipend mnapatiwa.
Yes.
And you're working every day.
Mtu akikuita saa 8
utaamka. Yes. Utaamka.
So kwa hiyo yote hiyo fare itakuwa ni yako.
Wewe ndio utajua vile huyu household wako atafika hospitali na uwezi lala.
Na akihitaji hiyo pamba na hiyo pads
utapeana saa hiyo juu wakati hiyo maybe ni hiyo household yenye iko vulnerable kabisa. Hakuna hata mtu wake utaenda kusema leta. Utabeba hiyo mzigo. Alafu kitu kingine ni challenge haswa mimi nimepitia. Tuko na watu kutoka nchi za nje kama Uganda, Tanzania. Mtu amekuja Kenya, ni household yako, hana ID, hana chochote, maybe ako na mimba. Ni challenge pia. Ukienda pale hawezi register SHA, hawezi fanya nini, ako tu hapo na anataka usaidizi kutoka kwa CHP.
Can I just
please because
you see,
okay, yes please sir.
Naona hii kazi ya CHP ni kazi ngumu sana. Kile wenzangu wamesema hapa ni kweli, tunapitia hali ngumu because unapata uko na hizo households pale, services kwa zile public hospital zile ambao tumekuwa attached kama CHBs, unapata vitu zingine hakuna. Ukipata kama huyo mama ambaye ni mjamzito anaenda kujifungua, amefika pale ajifungua, yes maybe akona uwezo wa kulipia hiyo SHA, atalipia, but at the end of the day pia kuna pesa atalipa. Unapata SHA inalipa nusu kama amelazwa, na yeye kuna ile pesa analipa, SHA ilipi yote. You see? Na kwa sababu ya those challenges, alafu pia zile services kwa zile hospitali, zile facilities ziko low. Kuna vitu hakuna kama hizo umesikia hawa. Kuna mmoja nilipeleka nikashangaa, na ni usiku saa 9 usiku, nimepeleka mama kajifungue. It's serious. Naambiwa ni kwanza nitafute gloves za daktari.
Ngoja. Unaenda hospitali?
Napeleka
ama kuna mali nyingine? Hospitali.
Napeleka mama kajifungue. Unaona? Na ako amebakisha tu masaa. Nimeitwa saa 9 ya usiku. Nimetafuta gari, nimeomba jirani gari akanisaidia tukapeleka. You see? Kufika pale hospitali, kitu ya kwanza daktari anakuambia hana gloves. Just gloves.
Ni saa ngapi?
Saa 9 usiku.
So ukatafute gloves saa 9.
Sasa nitafute gloves. Kwa bahati nzuri kuna wakati tulikuwa tumepatiwa gloves kwa nini zetu. Ikabidi nirudi kwa nyumba nikalete zangu.
Huyo mama sasa yako wapi? Amewachwa hapo.
Sasa ako pale, daktari anagoja nimletee gloves ndio aanze kazi. You see? So tunapitia mambo mingi na tunapata kwa saa hii namba ya wale watu wanatibiwa kwa hospitali za serikali imerudi chini. Wengi wamepotelea kwa my chemistries because pale watu sana kwa hizi vijiji zetu unapata yule mtu ambaye anategemewa pale maybe ni mama mzee ana kazi, na yule mama kazi yake ni kufua, anafanya kazi ya kutafuta kufulia watu. Hata ipata kila siku. Ile familia iko na watoto 3 wote wako shule. You see? So ukitokezea shida ya afya, hiyo shida inarudi kwa CHP, yule mwenye ile household. Na before ukienda pale kwa ile household umeitwa, before aanze kuongea jambo lingine, labda ni mtoto mgonjwa, unapata maybe yule mtoto ile shida ako nayo ni kukosa kula vizuri, amekosa chakula, maybe ni mtoto wa under 2 years, amekosa ile chakula bora. So magonjwa, shida ni kukosa kula. Sasa utaanza pale kwa chakula. Huyu naona na ile stipend ni 3500.
So
you see, so hii mambo ya SHA at least Linda Mama ilikuwa inatuokolea. At least Linda Mama ilikuwa inatuokolea sana sisi ma CHP. Because ilikuwa inaturahisisha kazi. Hata kama utasaidia au utasaidia kama sahi. Sasa unaitwa mahali unaanza kwa kununua unga kabla mfike hospitali. Unaanza kwanza kununua unga, unapata hata hiyo nyumba maji ya mtungi 5 shillings hawana. Oh, come on. You see? So imekuwa kazi ngumu sana sisi kwetu. Unaanza pale kwa nyumba, ndio chukua hatua sasa ndio utabeba mama upeleke hospitali. Au watoto watakula nini? Ukifika hospitali kuna challenges. Unaweza kaenda pale ule mama atibiwe ama ule mtoto atibiwe, atoke at the end of the day. Akitoka kuna dawa kuna huko ameandikiwa.
Kuna dawa kuna wapi?
Hospitali hakuna dawa.
Daktari, I'm sorry.
No. Ukitoka pale na hiyo dawa, wewe ndio unapatiwa kadi. Huyu mtu uliacho umenunua maji na umenunua unga moja na sukuma 2 kwake, ndio umekuja hospitali. Tena pale kuna
uliwacha chakula kwa nyumba, ndio watoto wakule, ndio mama apeleke hospitali. Yes. Na akifika kwa hospitali unaambia uende ulete gloves number 1, hakuna dawa.
Naona. So unajiangalia, unaona sasa hata kumpeleka hospitali kazi ya bure kama hawezi kupata dawa. Unabidi wewe tena uhangaike ununue. Uanunulie hizi dawa. You see, yani
maybe so what I can say, as you can see, and the numbers they are giving are true. From the data we have, SHA data. This is our own data. At level 2 and level 3, private hospitals and mission hospitals are accounting for 79% of all visits. So it means that Kenyans who are going to public hospitals are only about 20-21%. The data at SHA actually shows this. And what this says is that at the lower level, at level 2 and level 3, where most of our CHPs are attached, that the county governments have literally shut down. They have let us completely down. And it goes against the rhetoric that we hear from the politicians who are saying that public hospitals, the amount of money they have received under SHA, they have never seen since independence. Now, when you go to actual public hospitals, you don't see the money. And we are wondering, we passed one of the laws, the Facility Improvement Fund Act, which was supposed to make sure that even your level 2, even your level 3 can open a bank account, and when they see patients under SHA, that money is supposed to come back to that facility. But what we have seen in many counties, that the level 2 facilities and the level 3 facilities do not have critical supplies, which means they are not receiving the money that was promised under the law. And I know what has happened. A lot of these counties, they see patients at level 2 and level 3, but the account number that they have given to SHA belongs to the Department of Health. So all the money that's supposed to be coming directly to the level 2 or level 3 bank account never gets there. So this is
that's why you will go there and they will tell you to bring gloves.
There will be nothing. Let me give you another shocking statistics. Out of the money that SHA has paid out, 40% of the money of SHA has paid out has gone to specialized services. You know, and this specialized, I'm talking about orthopedic surgery, general surgery, neurosurgery, urology surgeries. Now, how many hospitals are seeing those specialized services? Only 28% of claims are
specialized care,
specialized services. So 28% of claims are eating 40% of the money. Yet our level 2 and level 3 hospitals don't have resources.
And the level 2 and level 3 are actually taking up the bulk percentage of
They
the
are
ailments that people are
they are
presenting to
saying
hospital with.
bulk of patients.
And the money's
So
not going
every
there.
every time we see our politicians visit hospitals, you never see a picture of them at a health center. You never see a picture of them at a dispensary. You always see a picture at the referral hospital,
And the few people
at
are
the
there.
big private hospital with very nice cameras and nice things. But they never go down there where the services are actually being accessed. The other thing I would mention, do you know, SHA right now has a funding deficit, as I said, of about 3 billion shillings a month. If we just reduce the contribution to 300 bob per person, and we got 10 million Kenyans to pay, we have no gap. So why are we insisting that the contribution has to be something unaffordable? We can put it down, make it affordable, more Kenyans will be able to pay, and we will be able to meet the funding deficit. I also want to put this challenge to especially the county governments. Under the NHIF, and I really hate it that politicians have been spending the last few months just telling us how NHIF was bad. And yet most people know it had challenges, but there were some things it was doing well. For example, Linda Mama was great. Okay? For example, Edu Afia for children who go to school was fantastic. We had the orphans and vulnerable and elderly people package, indigents, wale wazee ambao walikuwa wanalipiwa. That was fantastic. Yeah, even what's the? Even the UHC was perfect. So there were a lot of good things, and we told them keep these things.
I just want some clarification just from some of you here. Under Linda Mama, wamama walikuwa wanaingia hospitali kujifungua bila malipo.
Sasa wakati wa Linda Mama, kulingana na sisi ile vile kwa ground kuiko, wakati wa Linda Mama, every month, maybe kwa wa unit, hata ripoti ya hospitali mali huwa tuna report, wamama walikuwa wanajifungua. But now unapata ni hili mama akajifungulia private. Unapata mama uko naye kwa household ako na mimba, lakini wakati wa kujifungua ukifika hata utajua, maybe aende nyumbani akajifungulia nyumbani kienyeji, ama apelekwa private, kwa sababu ya zile challenges ziko wapi kwa zile hospitali za serikali.
Okay,
let's hear from Wakili here.
Yeah.
Thank you. I'm not really a medical practitioner, but from what I'm getting from our panel here together with our daktari, I'm just wondering, was this system worth that we told that was worth 100 billion plus? Was it worth it at such a time? Because probably could have improved our maternal health care. We could have improved the welfare of our community providers. We could have done something with equipping the hospitals. And come to think about it, this was rather a very rushed system. It's whereby something is thrown to your face. So you're still trying to figure out, ini kiti hospitali, what is it, what does it do, and all that. There was very minimal consultation, just from basing my arguments on what he has said. There was very minimal consultation that were done. Because I believe that some of the things that we are saying, even the gap that you need to pay 1 year before, we could have at least have had.
This is the Situation Room, the only way to start your day.
Home and